Hi, everybody. And thanks for having me. It's really excited and also pretty nervous to be here today talking to everybody about this. And so let me introduce myself quickly. My name is Henderson. I'm a physical therapist, but prior to becoming a physical therapist, I was a strength and conditioning coach. I started my career as a strength and conditioning coach back in 1995. I got my CSCS back then and worked as a strength and conditioning coach in a physical therapy clinic for about 3 years, and then decided, I really like this rehabilitation stuff, so I want to go to PT school. So I brought my background in strength and conditioning and exercise science into that field, and part of what drove me to do that was I had lots of questions as a strength and conditioning professional that really weren't addressed in my curriculum, and there was lots of holes in my knowledge at that time that I felt could probably be addressed by understanding a little bit more about how the body moves when the body's not functioning well. And so I started PT school, went through PT school at UTMB in Galveston, and I learned a lot. But then where I really started learning a whole lot was when I started practicing as a strength and conditioning coach with a physical therapy license. And then I had another jump in my education when I started interacting with other professionals who had the same questions that I did about rehabilitation, exercise science, and pain. And it brought me to places like Soma Simple, where I met all kinds of wonderful people, where I argued with all kinds of wonderful people, and Facebook, where I still argue with all kinds of wonderful people. But we keep it, we try to keep it pretty cordial. But I love what I do, and over the years I've managed to make some sense out of exercise science and pain science that I hope translates well to what we talk about here today. So may I ask just briefly, how many physical therapists or about to, student physical therapists do we have here today? Okay. Okay, great. Now, how many massage therapists do we have? Also great. Now, how about strength and conditioning coaches only? Nice. Excellent. Excellent. Well, hopefully we have a little bit of something for everybody here. So if you ever want to know what I'm about or who I am as an individual, what I like to do, you can usually catch me in one of these 4 domains. I'm either with my family, my lovely wife and beautiful daughter. I'm either out in the Texas Hill Country, doing hunting and that sort of thing, hunting and fishing, or I'm yelling at somebody on social media, and I'm a huge Star Wars fan. So if you want to connect with me on any level, you can meet me here, anywhere. Okay, and but these are my passions. These are what I love to do, and in addition to doing what we're doing here today. So what I hope you learn today, I want you to understand, and I think probably if you've been paying attention at all to what's been said so far, that we're in the midst of 2 pretty significant healthcare crises right now. And these 2 crises have remarkable similarities to each other, in that there's a lot of things we can do to improve in its management. How we look at the problem, how we interact with patients, how we treat our patients, how we coach our clients. And then what we can do now to start making this better. So in this case, I'm talking about, obviously, the problem of persistent, chronic, or untreated pain, or poorly managed pain. You guys have probably already gotten a pretty good background on this so far, but I'm going to touch on it just a bit. The other that I think accompanies this crisis is the problem of physical inactivity in our country. So with persistent pain, you've probably already seen several presentations on this, so I'm not going to go into it too deeply. It's a very high prevalence, heavy indirect and direct cost, and it mirrors the challenges of many chronic diseases we face today. You'll find that we talk a lot about pain, but there's a huge problem with managing most chronic diseases. heart disease, diabetes, healthcare providers, costs, all this stuff way out of control for most of the chronic and persistent problems that we face today. And generally speaking, with persistent pain, right now we're doing it wrong. We're not looking at this problem as a society, as a culture, providers. I think we can do much better. I think there's a lot of potential here. There's a lot of upside to what we can do for people who are in pain. And that's obviously what we're here today to talk about. And why doing it wrong matters. These aren't small things. We say, well, the patient just has pain, or the patient just, most of the time, persistent and untreated pain or chronic pain lowers the scores of most quality of life indices, high levels of physical and psychological distress, and pretty importantly, right now, there's decent evidence to show that persistent pain gets people into disability earlier, long-term disability, and which then, of course, leads to problems down the road. The significant financial, physical, psychological, and it's not trending well right now. The other problem is physical inactivity. We've been on this earth as a genus, here for about 2.4 million years, and we've beautifully adapted from an evolutionary standpoint to solve complex problems, interact with each other, and move around a lot, and do all kinds of really cool things with movement. But unfortunately, we've kind of solved, it's a little bit ironic, we've solved the complex problem of having to move. We've engineered a lot of movement out of our existence. And that goes a little bit counter. I'm not going to go all paleo. Okay? I'm not going no paleo. Okay? But I am saying that we probably are living a little bit out of sync with our evolutionary development. I think that's not too much of a stretch to say. Okay? We can do that and not go full paleo. Right? Okay. There's physical inactivity as a primary driver of chronic disease right now. It's a key element also, physical activity is, in managing these diseases. This is all kind of basic common sense type stuff. This is, call it a physical activity disease some. There's a really nice article by Frank Booth, happy to share with you. But this just shows all of the physical ailments that tend to pop up, and this is a terrible slide, but in terms of the wording, but there's lots of stuff that being more active or being inactive makes worse, and being more active generally helps. So pain and physical activity are both unprecedented modern healthcare crises. And the interesting thing is that they're both heavily influenced by physical, psychological, and social factors. They also influence the function of multiple systems and processes. Nervous system, the immune system, endocrine system, musculoskeletal, and even our genetics. But there's one thing that distinguishes them among other chronic diseases is that they're also addressed by a wide range of health professions. Name some healthcare professions that deal with painful problems on a daily basis. Anybody? Doctors. Surgeons. Acupuncturists. Occupational therapists, physical therapists, massage therapists. Chiropractors, of course. There's so many. Podiatrists. And now we see a lot of fitness and strength and conditioning professionals getting involved, right? And this has become somewhat of an issue among physical therapists who get bristled about that kind of thing, right? We see a personal trainer or a strength coach assessing someone's pain, and we get a little bit nervous about that sort of thing, right? And they get, and let me just be straight from a strength and conditioning standpoint. We get nervous as a strength coach. Get nervous sometimes when we see physical therapists prescribe exercise, right? I mean, when I first saw a stool scoot, everybody know what a stool scoot is? This exercise, you sit on a stool and then you have the patient kind of drag themselves across the clinic. When I saw that, and I had my background in strength and conditioning, I kind of went, well, maybe there's some gaps here in what we know about movement and exercise. It always reminded me of my dog when she's got something, and she's just kind of, that's all I can think about when I see the stool scoot. But the reason I bring that kind of stuff up is not necessarily to laugh at the people who do that sort of thing or anything like that. It's just kind of funny stuff, but it does really, really underscore the fact that we don't understand what we're doing when we're doing these sorts of things with patients or when we're doing these things with our clients. So they're fundamentally misunderstood and also poorly managed. So if we look at poor management and poor understanding, there's some examples of poor management in terms of pain. We got spinal fusion, which is generally a disaster. Spinal injections, the overprescription of opioids, which is actually leveling off. Right? The use of opioids is starting to level off, which is like, hey, that's great, right? The downside there is that heroin is up. That's not so good, all right? So it's always a kind of a glass half full, half empty type of thing. Poor education. I work in a hospital now as an administrator of a large physical therapy department, and I hear people walking up and down the hall constantly talking about their patients in pain. Doctors, residents, interns, physical therapists. And it doesn't take long to realize that we are undereducated in this domain, severely undereducated. Orthodox manual therapy, I think, I feel safe in saying this is another example of poor management. Classic orthodox physical therapy in the way that it was traditionally taught by very, very well-intentioned people who just didn't have all the facts. And then, of course, Dr. Google. You put in, my elbow hurts, and WebMD turns back elbow cancer, right? But we also have a poor understanding that leads to this management. Our beliefs, our attitudes, medical education, social interaction, cultural norms. Barrett Dorco, when I first met him, used to talk about the culture constantly, its influence on our pain behaviors and how we manage pain, and it's absolutely, he was dead on. He still is dead on about this. I really encourage you, if you haven't read what Barrett has to say about pain and culture, boy, I tell you what, it'll change. If you're a strength and conditioning coach, you should read Barrett Dorco's work. You'll learn a lot. If you're a physical therapist, you should read his work as well. You'll learn a lot. But then we have a problem with exercise too that's very interesting. We also have generally a poor understanding of exercise. Poor programming, we see it all the time. Overdosing, underdosing, poor individualization, lack of variability, lack of exploration. We could be doing so much more with exercise and we're not. But again, that goes back to poor understanding, our beliefs and attitudes about what exercise is, what it should be doing, which is generally right now dominated by aesthetics. I want to look better. I want to lose weight. As if that's the only metric that there is with respect to physical activity. Where did we go wrong? Well, part of the reason we went wrong with pain is because we had been traditionally making decisions on limited information. That drove what I would call the orthodox or traditional manual therapy biomedical model. We looked at physical structure, and that's how we made our decisions. We did this, something happened, and then we said, okay, well, it happened because of this. We didn't have all the information. You come to a room of people like this and you go, wow, this we're doing pretty good. You can be proud, I'm proud to be around people like you who want to learn more. But then when I go home and I see this, I go to the gym, I see this kind of stuff. So whenever you think, well, I think we're doing a better job, sometimes we're not. And I think there's a lot to learn about this. And I'm not putting we're laughing, it is kind of funny, but at the same time, it's not. And then we get this all the time. The one thing that you could do to fix back pain and poor posture. And this stuff tends to sell because People are busy. You know? And then, of course, we've got things that kind of crank up the stakes just a little bit. Who's ever heard of failed back surgery syndrome or post-laminectomy syndrome? Who's ever heard this term? Failed back surgery syndrome. We actually have a diagnosis for what happens when we screw up. Serially screw up, one after the other, and all of a sudden we diagnose you with failed back surgery syndrome. So I had an idea, I fixed it, and we're going to call it failed back surgeon syndrome. I'm putting this in as a suggestion to the AMA, and they haven't responded back yet. I sent the email last February, but I'm convinced they're going to get back to me on this. And then there's just this conceptual dumpster fire. I like the term dumpster fire. It's just a mess, you know. Pain is, we hear this. Who's ever heard these terms? You can just let me know. Pain is weakness leaving the body. You know, strength and conditioning professionals that don't know a lot say that a lot. Pain is weakness leaving the body. No pain, no gain. But then we also have other things that are equally not accurate. Not a good thing to say to people. Don't do it if it hurts. If it hurts, it must be doing something. I hear patients tell me that all the time. Well, if it hurts, it must be doing something right. No matter of speaking. And then we also get, what exercise do you do? It's a physical therapist in here. Who's ever had someone walked up to them on the street and said, hey, my shoulder hurts. What exercise do you do for that? What? You know, I've had knee pain for 7 years. You got an exercise? You know? And you know, that to me is a failure of our, our understanding of what pain is and the role that exercise has in managing it. It's a failure. And you have to unpack a lot. You have to do a lot to get somebody from what exercise do I do for my shoulder to actually getting that person to feel better. Who's ever had a chief complaint of a patient handing you their MRI report? Tell me a little bit. I said, Ms. Johnson, it's nice to see you. My name's Rod. I'll be your physical therapist today. Tell me about what brings you here. Won't say a word, hands me the MRI. We're going to have some work to do there, okay, before we ever lay a hand on the patient. But not all is lost. Now, this is kind of a bummer, right? I always feel like whenever I do this talk, the first 20 minutes is kind of a bummer, okay? But not all is lost. Exercise does play a meaningful role. Physical activity, probably more generally, plays a meaningful role in the resolution of persistent pain and chronic disease. And we're at the front lines. We just need to recalibrate our understanding a little bit. A lot in some cases. So we get too bogged down here in some of these definitions and terms, but the IASP, who knows who the IASP is? Good. Okay. Good people to follow generally, if you want to keep up with the study of pain, is the International Association of the Study of Pain. 2009 or 2010, I can't remember what year it was, Diane, but it was the global, you know we had a global year against musculoskeletal pain? It was 10. 6 years ago we had a global, who knew? I've discovered about this global year, or this year against musculoskeletal pain in 2014. They didn't do a very good job of advertising it. But they said that exercise is an integral component of pain management. But here's the problem. And this is a big problem, and this fuels a lot of misunderstanding and misapplication. That the type and the dosages aren't very clear, at least from an evidence standpoint. There's some proposed mechanisms of modulation of ascending pathways, facilitation of descending inhibitory pathways, and then also the role of muscle, skeletal muscle, as an endocrine organ. And there's some fascinating research being done, but that being said, we still don't know exactly how exercise helps, how it makes a difference. And we think we're helping, but here's the honest truth. And we have to be honest with ourselves about this right now, because we as physical therapists, as strength and conditioning coaches, we want to proudly be able to say, we're making a difference. What we do and what we believe is right, and we're making an impact here. You hear that all the time. I just want to make an impact. I still don't even know what that means. But the effect sizes of exercise on conditions like chronic low back pain, and I use chronic low back pain because it tends to occupy the bulk of the research right now, that's pretty small. The effect sizes for what we do, almost any kind of exercise, it doesn't matter what kind. No single form of exercise seems to come out as far superior than any others. Core training, yoga, walking, advice to stay active, strength training. And there's a questionable link between, here's what's really interesting, there's a very questionable link between the clinical outcome that we get with our patients. How do they feel better? Did the Oswestry score go down? Did the visual analog scores, they go down? Those people aren't necessarily getting stronger and moving better. So that's another thing we kind of have to overcome in terms of what we don't fully understand. We'd like to think, well, I did this exercise, this muscle got stronger, therefore the patient got better. We really can't say that right now. So exercise we know seems to be beneficial, but not tremendously so, and probably not for reasons that we used to think. So how do we make sense of this? One thing I think we could do as rehabilitation professionals, as strength and conditioning professionals, is follow the trends that manual therapy's gone over maybe the last 15 years. And that's a transition from a biomedical model of how we look at things to more of a broader psychosocial framework. And that's a very vague statement. But I'm going to give you a couple of examples. We're going to talk about specificity. Strength and conditioning coaches, who knows what specificity is? All right. Zach, can I put you on the spot? What is specificity?
Specificity, making it specific to the task.
Yeah, we know this, right? Okay, so we do something and we get a specific response. Specific adaptation to an imposed demand, is what we used to say. Okay. And then we're going to talk about another example of operators versus interactor. Now, I can't remember who coined this term. Something Jacobs? Yeah. Okay, so yeah, but I'm telling you that this helps. One of the things that we've learned, and one of the big problems of manual therapy, orthodox manual therapy, is the principle of specificity. Specificity says we get out what we put in. I move L5 on S1, I'm going to get improved mobility L5 S1. I mobilize the shoulder in this specific direction, and I'm going to get a specific change in a specific direction of movement. We know now that's not an accurate representation of what actually goes on. We know that there are specific effects, and then we know that there are non-specific effects of what we do. So now, most of the time, we know that these things exist. And this has changed our perspective on how we provide manual therapy. At least it usually does. I went and taught a manual therapy course, or a fellowship course. I teach a course on strength and conditioning to manual therapy fellows. And there's still quite a bit of, hey, I push here, kind of tab A and slot B reasoning for manual therapy. But as a rule, we tend to be coming out of this. We're learning that there are widespread, system-wide effects for manual therapy. But when it comes to exercise, that's not generally appreciated as much. We usually look at specific effects of exercise. In other words, this is a strengthening exercise, okay? You'll hear that said by physical therapy. I'm doing this to strengthen the VMO, or I'm strengthening the patient's infraspinatus. I'm strengthening this is a rhomboid exercise. But it's important to remember that with exercise, just like there is with manual therapy, there are specific effects, specific mechanical inputs, but they generate some fairly non-specific processes. I'll give you a little example. We know cardiovascular exercise generally improves the health of what? Cardiopulmonary system, central and peripheral mechanisms, that's pretty straightforward, right? But there's also non-specific effects, improved metabolic function, muscular strength, influences of cognition and affect. Resistance exercise also has non-specific effects. Yeah, we get stronger. We have improved output. But we also see changes in metabolic function, cardiovascular function with strength training, what we would characterize as strength training. We still see cardiovascular changes with strength training. And we see changes in cognition and affect. So manual therapy, exercise, both operate on very similar landscapes. That's probably why we use them. So I'm going to encourage you to reframe specificity just a little bit when we look at exercise. I want you to look at exercise as a means of imparting progressive physical and psychological stress to your clients. And that's going to be a little bit of a departure from how we traditionally look at exercise, right? I'm doing this exercise for this muscle, as opposed to I'm doing this exercise to help my patient be more adaptable in this environment. And being adaptable in an environment is not just a matter of being physically strong. I love strength training. I love it. But I mean, we have to acknowledge that there's a lot more going on to what we're doing. And the dosing of your exercise is going to have to be dependent on a variety of factors, not just physical. We pretty much, I think right now we're decent at knowing a patient's physical limitations. In other words, making sure they're not harmed by physical activity. But I think we do a pretty piss poor job of acknowledging the psychological ranges that are appropriate for movement in our patients. And we're not classically trained in that. But I'm telling you, it's so critically important. And then also understanding the social and cultural factors that play a role in exercise prescription. I was at that fellowship course last weekend. We had a very well-credentialed physical therapist. We were doing a squat clinic. We were doing a squat lesson. Okay, we were just talking about squats and the ability to squat. And one gentleman I said, okay, Mike, I want you to squat down. He said, okay. And he goes, and he's just, extremely not breathing, didn't look very healthy, shaking and rounding. It just looked awful. And I said, hey, Mike, you thought about trying to position your feet maybe just a bit differently? He goes, no, I've never really thought about that because I know when we squat, we need to keep our toes pointing straight forward. And I said, who in the hell told you that? He says, well, I know who did, but we're not going to get into that. Okay, all right. But I'm going to say, all right. I say, look, let's play around here just a little bit. I want you to try to just let your feet come out just a little bit. He said, all right. He came down and all of a sudden, no shaking, no extra tightening. He was breathing and he was talking. You know, it wasn't a big thing, but it was a big thing. And then all of a sudden, he started seeing, but he goes, wow, it's okay to do that. And so we got online and looked at pictures of people who lift a lot of weight. And we tried to count how many people had their toes pointing straight forward. Okay? We came up with about that many. Okay? People squat differently. But this well-credentialed clinician thought that this was how he needed to squat. And by extension, what do you think he was probably telling his patients to do? Yeah, so, you know, it's important to understand that we're not just dealing, this was not in him. Now, he had some physical things that we could work on as well. He had a little bit of mobility, that kind of stuff we could work on. But generally, his squat improved tremendously by just making it a bit easier for himself. And I think we can do that with our patients. I love the terms operator versus interactor. Your clients need a coach, not a boss. We were talking about this earlier. Nobody likes being told what to do. Stand up, sit down. Okay, I want you to do this. I want you to pull here. Sit up straight, pull your elbows in. Nobody likes being told what to do. At least when I say nobody likes being told what to do, over long periods of time, being told what to do is not a sustainable curriculum. It's got to be an interactive coaching process that allows for flexibility and assessment, goal setting, coaching, building therapeutic alliance. These are all things that were really not in the curriculum of most of our entry-level physical therapy programs. Right? And the thing I like to say is keep the patient on their path. Bring them along their path. You don't have to drag them up your hill, okay? Which I think is what a lot of coaches and, I'm going to try to avoid, pinning certain systems, but I think we have a tendency sometimes, especially in the world of exercise today, with things like, the kettlebell community and CrossFit and things like that. I think there's a culture that we want to adhere to. I know I shouldn't be doing this overhead kettlebell snatch, but I know that's on the WOD today. I know that's on today's workout. So I did it anyway. The benefits of interaction are pretty amazing. And this really improved my ability to act as a strength and conditioning professional and a physical therapist all at the same time. It's been a really fun process. The client gets a better understanding of their body. That's an underappreciated element of what we do and how it responds and adapts to stress. It's greater motivation for physical through autonomy, mastery, and connection. It's much better to facilitate that level of motivation, giving the patient their recovery, instead of going, I want you to do this exercise and I want you to do it 30 times. I'll be back in 5 minutes. Get on the bike and I want you to pedal on the bike for 10 minutes. I'll see you in a minute. And we see that far too often. The wonderful thing that I've observed by interacting with my clients a little bit better, my patients a little bit better, is they go home and they tell people about it. Nobody goes home and tells people about prone on elbows. Lying on your stomach, and I did this great exercise, and but they tell the story of how you let them move in ways that are a little bit easier, a little bit more enjoyable. They talk to their family about that. Those are kind of idea viruses that a lot of times extend well beyond what you do as a provider. All right, physios, I'm looking at you here. Folks, you got to know basic guidelines of exercise, all right? I can't, look, if you're going to be prescribing physical activity, we gotta be up on this stuff just a little bit. Ben, is there an ACSM in the UK? Is it?
It's an NISM.
Okay, similar?
Yeah.
Okay, good. All right, so, this is really, really important. And I'll be honest, not a lot of physios right now would be able to have, gosh, it's terrible. I'm not trying to generalize, but it's difficult sometimes to have a conversation with a physical therapist about exercise. It can be, okay? Just like it's difficult to have a conversation with a strength and conditioning coach about rehabilitation. But at the same time, if we're going to be operating on this landscape of physical activity, physios, we got to be sharper with exercise. We really do. The current guidelines are pretty straightforward. 30 to 60 minutes of moderate intensity exercise, 5 days a week. Who knows what moderate intensity is? Does anybody? Anybody? Yes, ma'am.
But you're getting your heart rate up, but you can still carry on a conversation?
Yeah, that's one way of just kind of. Yeah, absolutely. So, can you say it one more time?
What I said was that you get your heart rate up, but you're still able to carry on a conversation.
Right. Getting your heart rate up to carry on a conversation, that's one way of looking at it. The other way that the ACSM generally looks at it is about 3 METs. 3 to 6 METs is what we consider moderate. If you've ever pedaled on a bicycle, an ergometer that generally tracks those sorts of things, that's not very difficult. That's not a high level of physical activity. 3 METs. So, we're going to talk. Metabolic equivalent. So when you're lying flat on your back, okay, there's 1 MET, okay? If you're Lance Armstrong, well, bad example. If you're if you and I go for a jog, generally around 8 to 12 METs. Well, for me, it's probably going to be closer to 8. I'm a slow jogger, but it tends to go up as you get more active, all right? 3 to 6 METs is moderate. Over 6 METs is, from the ACSM standpoint, considered intense. And that's not, when we say intense, when we think intense, what do we think? We think like CrossFit intense. Things are bleeding, you're puking, it's That's intense, and it is intense. From a subjective standpoint, that's intense. But from the ACSM standpoint, 6 minutes and higher, that's intense, and that's not that hard. Okay? And there's lots of ways we can do it. Modes of exercise, there's so many different ways. Remember, we said the type of physical activity that you have the patient do is not the primary consideration. It's a consideration, it's not the primary consideration. Cardiovascular exercise, good evidence. Strength training, wonderful. Neuromotor exercise, very good for balance and that sort of thing. It's a lot of fun. Flexibility, That's the general vibe of the literature right now, is that, yeah, you can stretch. What's it going to help? Nothing really. Does it help improve rates of injury? No. Does it make me less sore after exercise? Not really. Help me warm up and be ready to exert myself? No. But you can do it. Yeah. So flexibility doesn't really get a really good treatment from the literature, but it doesn't mean you can't do it. There's lots of ways to do this. What about pain? Remember, exercise is a component. It seems to help, but the mechanisms of effect are pretty unclear. We think there's anatomical changes, probably not. I mean, there probably are over a long period of time, but anatomy tends to follow the stress. Your anatomy changes over time, slowly. Physiologic changes, performance changes, psychological improvements, none of these accounts for the entirety of how exercise seems to play a role in pain. So what do we do? All right, so we're going to implement client-centered, guideline-driven activity program. Who thinks that's lame? Who thinks that is a generic, weak-ass recommendation? I do. I obsessed over that for a long time. So look, let me try to explain a little bit here. It's difficult for me to say, okay, I need you to take all your patients and I want you to start teaching them the kettlebell swing. I want you to start taking your patients, I want you to start jogging. I want you to start walking more. They all need to be on a bike. It's very difficult to take something that we're really very, very complex and has lots of variables and say, this is what you do. But I can tell you what will help. Stop doing dumb stuff. Okay, and look, I mean that with all due respect. When I stopped doing dumb stuff, like stool scoots in the clinic, okay, I started having to fill that time with things that were more meaningful for my clients and my patients. I got to sit down and interact. I said, look, this is the thing I'm going to stop doing. I'm no longer going to do this. I'm just going to sit with my patient and ask what's important for them. And what came out of that were exercises and activities that were a lot more relevant. And so I think when you just kind of evaluate, and you got to have a filter for what dumb stuff is. I can't really tell you what the dumb stuff is. It's out there. You'll know. You'll probably kind of have a feeling. You'll watch your patient doing it and you're going, yeah, that's kind of dumb. That patient looks dumb. This is not going to carry over. This is not going to last for this patient. I'm telling the patient to do this. They're doing it 5 times. They're never going to do this again when they leave. So here's some of the things I recommend. You just got we have to learn how to be humans. Okay? And it sounds like a funny thing to say. And it sounds like kind of a hokey thing to say. From Texas, where, be human sounds kind of like a hippie, thing to say, but it really is. It really is critical for us to understand how to interact with each other, how to listen. Your client is a human being who happens to be going through a difficult experience. They're not in knee pain. It drives me nuts when I hear a therapist say, I'm going to go see my knee, my total knee at 9. I got a total knee at 9. I got a chronic pain patient at 11. We possess skills to guide them into a better understanding of themselves through physical activity. And that's probably been the most powerful transformation I've had as a coach, as a powerful transformation I've had as a therapist. learning how to guide them into a better understanding of themselves, physically and psychologically. I don't know which one happens first. It's difficult to know that. Sometimes it works, and then, sometimes it doesn't. I mean, we just have to be honest with ourselves about that, and honest with the patient. Look, we're going to be doing these things, and I believe it's going to help you out a lot. We're going to be doing things that are relevant to what you need. Things that are going to be helpful for you, I believe. And if it's not helping you, look, I'm going to get you to somebody that's going to help. And I think this is so much more honest than saying, this is the exercise for you. I'm going to fix your posture, and then I'm going to fix you. Because, damn it, you need fixing. I just think, I think that stuff has to go away. I love this. I love using movement as a teaching tool. When I first started learning pain science, I was so excited. I read Explain Pain, and I had my patient in front of me, and I said, you know what? Pain is an output of the brain. You know what? Technically, I was right. Right? But we all know this. If you've gone through this process, you know what happens sometimes. People don't understand how to process something like pain as an output of the brain. And we know what sometimes comes out of that. Well, they said it was all in my head. Right? And it was terrible education. Okay? But when you use movement, manual care and movement, as opportunities for the patient to learn, it's not just about anatomy. You say, I'm pushing on L5. We teach our patient to develop a curiosity for how the body moves and responds to various levels of physical stress. And there are great opportunities to talk about hurt versus harm. The patient's going, that's a little uncomfortable. This fellowship, I'm using this fellowship as an example a lot. We had a cold front that came through Houston. It was like maybe about 20 degrees Fahrenheit. And the day 2 of my fellowship course, what I'll do is to wake everybody up, we'll go out to the parking garage. We have an 8-story parking garage. Everybody comes in and they're just kind of tired. And I get them to run up the parking garage. And I don't usually tell them to run. I don't tell them to run. I say, meet me at the top. They don't have to run, okay? But most of them do. A couple of them will take the elevator, and there's no shame in that. That's great. It's really, but that's what our patients do. We want our patients to have that kind of flexibility with what they do. Not just run up to the top with me. Get to the top. Do it your way. We could talk about hurt versus harm. We could talk about pacing, neurophysiology, coping. And we can use almost any physical activity to do that. We can do it on the bike. We can do it while we're talking about squats. We can do it while we're talking about deadlifts. We can do it while we're doing manual therapy. It doesn't have to be a standalone curriculum where we say pain is an output of the brain. Don't be afraid to calibrate the intensity and the volume of the activity, physios. Okay? Don't be afraid to take your patients into deeper water, physically. I know we generally don't want to hurt our patients. But if we know the difference between hurt and harm, we know that we're not going to harm the patient. Learn how to take the patient into deeper water. And when they're not compensating, when they're not coping, when they're having a hard time, you can bring them back. And then slowly take them back out again. But don't let your patient think the only thing that there is to do with exercise is either shallow water or all deep water. They can go from shallow to deep, and you can guide them through that. Promote movement variability. Give your client the space and permission to move authentically. And we're talking with that example with the gentleman with the squat. Let the patient move in a way that's easy for them, either conceptually or physically, and then modify the constraints. I think Feldenkrais is a wonderful method for helping patients do this. There's all kinds of body awareness techniques and things like that, but it doesn't have to be Feldenkrais. It can be, any movement. Give them space. Let them move. And it's a powerful way to facilitate autonomy. You mean it's okay for me to squat with my toes slightly out? Yes. It's absolutely fine. You mean it's okay to run this way? I don't have to run with a certain posture? I don't have to wear this certain shoe? No, man. Give the patient many ways to solve a problem and let them fail. Let them make mistakes. Let them fail safely, okay? But let them fail. And it's hard to let somebody fail when you're telling someone to do an exercise this way. This is the only way you can do it. Okay? Learn to coach. You don't have to look the part, clearly. Okay? You don't have to look the part of a fitness model. Okay? But learn to coach basic movements. Practice walking, running, longer distances, pick up heavy things, solve motor problems. Offer yourself a challenge from time to time. Stretch yourself. That way you're going to have a better idea what the patient's going through, what the client's going through. It'll help you relate. Just to summarize, pain and physical activity have a complex relationship that we don't fully understand. And that's uncomfortable. That's uncomfortable for us. We don't like not knowing. Now, uncertainty is a very, very uncomfortable place to be. Okay? But certainty is not where we are with this stuff right now. Appropriate use of physical activity. If you want to be a good coach, if you want to be a good physical therapist, you got to learn to develop your interpersonal skills just as much as you develop your technical skills of how to coach movement. It's absolutely critical. That's how I've come to make sense out of exercise over the last 20 years. I hope it makes sense to you as well. Thank you. We do okay.
Mm-hmm. All right, so we've got a little bit of time here for some Q&A. If you have a question, please put your hand up and we will get a microphone over to you as soon as we can. We've got a couple of volunteers here. One question that I had for you is that there are some personal fitness trainers in the room. So you addressed physical therapists specifically a few times, but I was wondering if you could also address massage therapists that are cross-trained or cross-certified as personal trainers or fitness trainers in some fashion.
Yeah, that's a difficult thing, and I've had lots of conversations with really, really good physical therapists, really good strength and conditioning professionals, and massage therapists. It's difficult to know where our boundaries end on this type of stuff. And I think sometimes we perseverate just a bit on those lines, but at the same time, you've got to stay in your lane to a degree professionally. And I know the physical therapists go, yeah, stay in your lane, strength and conditioning professionals. Okay, guys, that cuts across. It's the same thing. Massage therapists, I believe, have a legitimate right to say the exact same thing to us. Okay, I think you have to be comfortable with what you're doing, and I think you have to be credentialed. I think you have to have knowledge. I think you have to have technical skill, and I think if you're operating within your license, if you're operating within your knowledge, I don't see any reason why there can't be some overlap there, But I do see quite a bit of overlap where I think it goes a bit too far. I see personal trainers acting, assessing pain. The client walks up and goes, my back's been hurting for 3 days. Well, let's do this stretch. I think that's a mistake. And so I don't really know where the line is. I think it's another one of those fuzzy things,
Well, damn it! I hope you have that clear line right there.
No, it's not an easy answer. That's why these arguments online, they never go very well, right? Right? They never go well because everybody's got a decent argument to make, and the lines are fuzzy.
I've heard they go well
are
online.
Huh?
I've heard they go well online.
They don't go well online.
We've got a question in the back.
Hi.
Hi.
My name's Brenna. I'm a massage therapist, and I also teach dance, and I teach strength and conditioning. So I am a person that walks that midline. And I was a dancer my whole life. I still am a dancer, but I didn't take any coaching necessarily. I'm not credentialed to teach. But you say learn to coach. Do you have resources for us? Because I feel like there really is a need for people to teach movement therapy. And we don't always have to go the degree route in order to teach that. So I'm just looking for resources.
That's a really great question. The two organizations that I generally steer people toward with respect to this are either the ACSM, the American College of Sports Medicine, or the National Strength and Conditioning Association. There are other organizations as well, ACE and that sort of thing. And this is preference, I steer people that are in your situation towards those organizations. I know the standards that they set, and they tend to be fairly high. I know that they have options for people who don't have four-year degrees to get certified. Let me be very straight about this. I know a lot of physical therapists who have strength and conditioning backgrounds, or have a CSCS, the Certified Strength and Conditioning, who aren't very skilled at program design, and so the certification, I think, is one element will be one part of your journey to becoming a better strength coach. I think then it's a matter of kind of getting in, networking with other professionals that are doing a good job and being able to ask questions and interact and practice. That kind of stuff is absolutely, there's no substitute for that. So I would say, I'm not a big certification hound, but I do think aligning yourself with those organizations is a good step. That's what I recommend.
Thank you.
Yes. Yes, sir.
So this question comes from our online viewer, Catherine Schottmeyer. So many people in pain tell me that they need to lose weight to help their back, knees, etc., and thus feel stuck because exercise hurts too much to engage in it. How can you address this belief, considering there is poor evidence that exercise is a reliable means to lose weight?
Right. Yeah. Again, I'll go back to something I learned from Barrett Dorco. When the primary complaint is pain, the management of pain should be primary. And so what I usually tell them is, I understand you're concerned about your weight, okay? But right now, we've got to get you feeling a bit better, okay? We're going to use movement to help you feel better, okay? And then we talk a little bit about the role of movement in weight loss, which is substantial, right? The amount of movement required to achieve significant weight loss is a difficult conversation to have for people because it is substantial, okay? Meaningful weight, pretty significant weight loss anyway. So we've got to get enough movement out of the patient where they can first feel better and then want to move a bit more, okay? When they want to move a bit more, they tend to move a bit more. And then hopefully things work out and they lose some weight. But the first thing you have to do is divest them of the idea that they hurt because they're fat. That's a huge thing. Yes, you may be overweight, but that's not why you hurt. Okay? There's a big difference there. Once you divest them of that, then you can say, okay, now once they understand that, then you can work on getting them moving a bit better, and then understanding there's some things that we can do to help you with your weight as well.
We've got another question coming up over here. While the microphones are heading over there, one quick question for you. Yeah. Could you clarify from your perspective the difference between the type of between assessments versus differential diagnosis?
Well, do I have to do that without pissing people off?
No.
Oh, okay. Well, I mean, there's lots of assessments, okay? But right now, there's not a real good connection between assessments and a meaningful clinical outcome. And that's very different from a movement perspective. We talk about things like FMS, SFMA, and other movement screens and things like that. That is very different, at least in my experience, very different than the differential diagnostic process, which is generally a medical process. Mm-hmm. And I know the movement screen people, I know they mean well, but they've kind of built it up to be, in some cases, a bit of a differential diagnosis, injury prevention type of process, and I don't think they go very well together. As a matter of fact, I've not been overwhelmed by the ability of movement assessments in general to be of much use.
Okay, thank you. So our question here in the next second row, third row.
I can answer this, but present it. What I would like to know is there a movement for us to be more aligned? It just seems like we're too individualistic out there, you know, and it's like when you look at the medical field as a whole, there's just doctors and physical therapists and osteopaths and, you know, massage and manual therapists that are kind of excluded.
Yep.
Unless you really push it, you know, you may get paid by insurance, you may not. And, you know, it seems like a lot of the people in Northern California, they get referred to Pilates instructor or people like that for strengthening.
Yep.
And I don't know, it just seems like we need more togetherness, you know.
We're here. Yeah, you know, I mean, it's good stuff like this. You know? Yeah, but I mean, this kind of stuff this kind of interaction has to get bigger. We have to go out, and each of us, they can't just go home and compartmentalize to what we're doing. We got to go out and start talking to people. We got to start talking to our patients and have them talk to their families about it. I mean, that's how stuff has to kind of go viral. Yeah.
Mm-hmm. We've got another question over here behind the pillar.
Yep.
Yes, ma'am.
I had a question. I heard you know, kind of describing some opinions about good exercises. Some are better than others versus maybe kettlebell versus not. And I know exercises come in and out of favor. I'm certainly guilty of telling my patients not to do certain things because of what I've read. And after listening to like Peter O'Sullivan and basically the patient, if the patient values, let's say, I want to join the kettle club and that's really important to me, would you dissuade them from doing that exercise?
Hell no. The patient wants to do CrossFit. They say, I want to do CrossFit because all my buddies are doing CrossFit. Even though I think CrossFit has all kinds of crazy in so many different ways, I still say I want you to go ahead and do it, but we're going to do it in a reasonable way. We're going to do kettlebell work in a reasonable way. You want to run a triathlon? I think it's one of the dumbest things. Or you want to do a triathlon? I don't want to do that forever. But you know what? If that's what you want to do and that's going to get you more active, well, I'm going to help you do that. I mean, that's just kind of how it's got to be. Sorry.
And no prisoners were taken. All right, that actually brings us to the end of our Q&A time here. So we're going to have ourselves a little break.